One, please start. So we are live.
Okay. Good evening, everybody. This is for evaluation of anti-VEGF drug, molecule characteristics and their impact on treatment success. Okay, this is disclaimer. So, in what happens in diabetes, there is an impaired vascular function and impaired retinal blood flow. So, it leads to hypoxia, and the, due to hypoxia, vascular endothelial growth factor and prostaglandin growth factor they are released. So, it leads to neovascularization of the vessels and inflammatory cytokines released by them, so it will cause vessel leakage and edema in macular and retinal in diabetic patients. So aflibercept targets vascular endothelial growth factor, the master regulator of the disease pathology, and additionally target the key lesion. Uh, there are two types of receptor: vascular endothelial growth factor type 1 and vascular endothelial growth factor type 2. So, what happens in VGF? Uh, this aflibercept, uh, we inject intravitreally, and then it leads to decrease inflammation, decrease in neovascularization, decrease in retinal vasculature leakage and edema. So it affects in VGF R1, and second action is on uh, second domain 3 VGF2 receptor. It binds VGF A. It decreases inflammation, neovascularization, retinal vascular leakage, and edema. So basically, we are treating with the vascular endothelial growth factor A and B only. Okay. So several. Okay. So several molecular factors determine how a drug interact with the body. There are few factors that affect the vascular endothelial cells. First, aflibercept, it causes binding affinity. It affects binding affinity. Its potency is important, and the elimination of half-life and clinical targets and molar doses. The five factors are important for VEGF, anti-VEGF action. So, binding affinity, there is a concept that there is a lower binding capacity, there is a higher affinity for the drug. So, aflibercept was found to have statistically higher VEGF. Now it's 0.172. So less the value, and it has a more binding affinity for diabetic patients. Uh, so aflibercept was found to have statistically higher VEGF binding affinity than bromacizumab and ranibizumab in head-to-head study. And a second potency that determines the required concentration of drug to produce a defined effect. So in faricimab, the value is not available. In ranibizumab, it is 10.82. In brolucizumab, 5.74. And in aflibercept, it 2.42. The lower the potency, the higher the drug affecting the. So data from the independent study estimated human half-life. So there is a human life half-life of aflibercept is 9.1 to 11 days. Binding target determine the downstream effect of a drug of a disease pathology. Aflibercept, it affects the multi-target VGF-A and PIGF. They both are important. Aflibercept significantly decrease the intravascular VGF. VGF is the vascular endothelial growth factor. It decreases the, VGF and prolactin induced growth factor levels from the baseline to 2 months to in patient with diabetic macular edema. Targeting additional pathway beyond the VEGF pathway further improve efficacy outcome? There is a question. So there is a angiogenetic factor plays a critical role in the development of edema, retinal vascular permeability, inflammation, neovascularization, and vessel stabilization. So as I told you, the aflibercept affect the VEGF1, VEGF-A and VEGF-B. Both the receptors are, it affects both the receptor. So it decreases the vascular leakage, inflammation and pathological neovascularization. What happens is normally neovascularization, the vessels are very fragile. So it tends to break down easily, and so the complications of the diabetic macular edema, diabetic vitreous hemorrhage, and blurs in the retina, that all happens due to the neovascularization, and due to that leading it to macular edema. And type 2 receptor, that is endothelial cell proliferation, migration, survival, and inflammations. They both are observed. So in the angiotensin 2 type 2 pathway is a relevant target for the treatment of exudative retinal disease. During angiogenesis, angio2 is unregulated and competitive binds type 2. There are two different studies. Bayer and Reginon have investigated angiotensin 2 pathways in combination with aflibercept in the RUBY and ONX studies. Uh, in RUBY ONX study, targeting both the angiotensin 2 and VEGF R pathways did not provide additional improvement in vision. Uh, yeah. So these are two different studies they have observed. Unbalanced study design favoring faricimab and the additional angiotensin 2 targeting with faricimab, and did not confer any additional clinical benefit over aflibercept. So there is a chart is there. So the effect of ranibizumab and faricimab. So both clinical study after one injection. So faricimab failed to meet the primary endpoint of the superiority to ranibizumab for BCVA gain at week 36. Level of angiotensin 2 inhibition were similar between agents, and suggesting that the angiotensin 2 molecular of faricimab may provide no additional benefit over anti-VEGF monotherapy. Aflibercept shows the most durable and robust superior suppression of VEGF and angiotensin 2 versus romosozumab and ranibizumab. So aflibercept delivers the comprehensive and highly durable targeting where it matters. We conclude that the binding affinity is very low in aflibercept, and estimated human life is more. In aflibercept, it is 9.1 days, and equivalent molecular dose is 1.0 raised to 8. And number of target is multi-target, 4 targets it's affecting, and potency is 2.42. Potency is less, the effect is more. So this is the additional pathway. So guideline, what is this? Diabetic macular edema treatment guideline in India. All India Ophthalmological Society Diabetic Retinopathy Task Force and Vitreoretinal Study of India consensus statement, their jointly given statement. The laser treatment has been shown to be an effective treatment option in the management of diabetic in early pioneering studies compared to the sham treatment, but is currently in the era of anti-VEGF, clearly not a standard care of treatment anymore. Corticosteroids are important in our armamentarium of drugs in treating diabetic macular edema patient, but largely in a second choice level. So these are the outcomes, the diabetic macular edema. Aflibercept provides unsuppressed vision gain with an excellent steady profile across multiple indications as demonstrated in the wealth of RCT and real-world data. So this is a real world data. So greater than 25,000 patients are benefited, over 13 million patient years of exposure, and now licensing totaling six indications. Then diabetic macular edema, CRVO, BRVO, central retinal vessel occlusion, branch retinal vein occlusion, neovascular glaucoma. There are all the indications. So in summary, aflibercept target VGF and P prostaglandin IGF level, thereby inhibiting downstreaming signaling via VGF1 and VGF2, which is the more master regulator of pathological angiogenesis. To date, both preclinical and clinical data suggest that there is no additional benefit of targeting alternative to the VGF signaling pathways. And separate independent studies suggest aflibercept has a greater binding capacity for VGF-A and a greater potency and a longer half-life than other variable anti-VEGF agent. This factor contribute to the strong VEGF suppression seen with aflibercept. So there is, in conclusion, there is a more greater binding affinity to VEGF-A and the longer half-life and a greater potency of aflibercept. So now with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be a limited potential for improvement in the functional outcome of patients. Thank you. Hello.
Yeah.
Yeah.
Hello.
Any questions?
Sir, we can have the questions later on
Okay, no
after Dr.
problem. Yeah.
Kaushal's talk. Yeah.
Yeah, no problem.
So
Next.
I would like to thank Deepak sir for giving a valuable talk. So we can have the next presentation from Dr. Kishore, Dr. Kaushal sir. I'll just present the. 1 second. Yeah. Sir, my presentation is visible, right?
Now I close my presentation.
Yes, sir. You can close your presentation, sir.
Okay.
You
Yeah.
can
Yes,
close.
sir.
Yes. Sir.
Uh,
And Pratik, we can see your presentation.
Yeah. So welcome, Kaushal sir. So please, you can start the presentation.
Hello.
yeah.
Deepak sir, you can mute now. Or tech team, can you mute him? So.
Yeah.
Done, sir.
Kaushal sir, you can start.
Okay. Diabetic macular edema from understanding to treatment. Start. Next slide. Hello.
Yes, sir. We can hear you, sir.
Okay. It is expected that the global burden of diabetes mellitus will continue to raise slow. What is DME? DME is a presence of excess fluid in the macular area of retina can result in loss of visual function. DME occurs when blood vessels in the retina leaks fluids and proteins into the macula, causing the macular swelling, which in turn affects visual functions. VGFA plays key role in pathophysiology of DME. VGFA increase vascular permeability and disrupt the blood vessels retinal barrier BRB in DME. DME is the leading cause of moderate to severe vision loss in patients with diabetes and a leading cause of blindness in working age population is in most developed country. DME can affect people with both types, type 1 and type 2 mellitus. Vision loss in patient with DME can have life-changing consequences. Patients with DME are typically of working age, so vision loss that reduces independence, productivity, and ability to perform daily function can have a drastic impact on their lives. For example, difficulty in performing near vision, in difficulty in near if uncontrolled DME can lead to severe visual impairment. DME can occur in individual at any age of diabetes retinopathy. Badly controlled diabetes and untreated DME can lead to severe visual impairment and blindness. See in the image, retinal and the treatment. See in the image, V, yellow circle and red circle. This is seen in the DME. Next. The treatment of visual impairment due to DME has evolved over time. Anti-VEGF treatment is the current standard care of visuals impaired due to DME. For example, aflibercept 8 milligram first approval in 2023. Next. What factors drive key mechanism behind the pathogenesis of DME? VGFA and PIGF act by VGFRs to promote vascular leakage and edema and inflammation and neovascularization. Next. VGFA, vascular leakage and edema and inflammation and neovascularization are the key mechanisms that drive and pathogenesis and prognosis of DME. Next. Aflibercept is the most globally available anti-VEGF agent that target multiple mediators to of retinal disease, VGFA, VGFV, and PIGF. Next, some VGFA and VGFV and PIGF are key drive behind the pathogenesis of DME. Aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of retinal disease. Next. Several sources of evidence support anti-VEGF choice for patient. Randomized control trials, real-world evidence, network meta-analysis, own experience, mode of action, internal guidance. It is a what is the VIVD and VISTA shows about impact of aflibercept in DME. In VIVD and VISTA study, clinically meaningful vision gains were achieved in patients who received early intensive treatment with aflibercept. Mean change in VCVA from baseline through the week 5 to primary endpoints. Next. VIVD, VISTA, and Protocol T clinically meaningful vision gains were achieved in patients who received early intensive treatment with aflibercept. Vision gains were observed as early with the first aflibercept injection. The patient received more than 8 injections through 1 year and maintained vision gains achieved during the initial loading phase. Across all three studies, patient treated with aflibercept gained on average more than 10 letters. At the week at the week 5 to primary endpoint, aflibercept is demonstrated superiority to laser in VIVD and VISTA. Next. VIVD and VISTA delaying aflibercept treatment lead to poor vision outcome. Next. What to meta-analysis and accept international guidelines recommended for the treatment of DME. Cochrane's meta-analysis reviewed evidence from major studies in investigating the efficacy of anti-VEGF agent in DME. Methods systemic meta-analysis RCT is providing a level 1 evidence baseline of anti-VEGF agent includes 24 studies, 6007 patients with DME and visual acuity generally between 20 to 220/40. Next. Other meta-analysis suggest aflibercept is the most favorable treatment of patient with DME. Next. International guideline and recommendation suggest aflibercept should be the drug of choice in patient with VCVA less than 69 letters, 20/40 or worse. Next. Uretina guidelines, aflibercept is the drug of choice in DME eyes with baseline VCVA below 16 letters, 20/40 worse, and its superiority to bevacizumab over 2 years and over ranibizumab in first year of treatment. ACN recommendation in patient with worse VA worse than 6/12 aflibercept may result in more rapid visual impairment and than ranibizumab over 1 year. Though this difference was not statistically significant in 2 years of DRCA NAT protocol T study. Diabetes Canada guidelines superiority of the aflibercept was noted in the group of participants with worse baseline visual acuity. German Ophthalmological Society guidelines, there is evidence of possible difference in the drug efficiency in patient with diabetes macular edema of the disadvantage of bevacizumab at the visual acuity less than equal 20/50. Next. Can these guidelines and meta-analyze inform anti-VEGF treatment in clinical practice? Data from Moorfield Eye Hospital and FRB registry assess the efficacy of aflibercept in patient in clinical practice. Poor baseline visual acuity in commonplace in up to 2/3 of patient in clinical practice. And the adjective next BIM T and E with aflibercept initially in 1 year can provide it clinical meaningful visual outcome over the 2 years. 50% of the patient were more than equal to 12 treatment intervals at the end of the year of 2, 69.1. Hirano, the majority of the patient with DME achieved 16-week treatment intervals with an individual T&D regime with aflibercept initially in 1 year. Baseline 60.5, year 2 66.6. 66.7 of the patient were on Q16 treatment intervals of the end of the year of 2. Next. JADE aflibercept initiate after 5 monthly loading dose provides significant visual impairment in patient with DME. Summary. Aflibercept can achieve meaningful vision gains in patients with DME as demonstrated by the RCT's meta-analysis and international guidelines and recommendation suggest aflibercept should be the drug of choice when patient treating with baseline visual acuity less than 69 letters, 20/40 or worse. RWE highlights the effectiveness of aflibercept in clinical where the patient regularly present with poor baseline visual acuity less than 69 letters. Patient with visual impairment due to DME, particularly those with baselines BCVA less than 69, letters 20/40 hours can achieve meaningful vision gains with aflibercept compared with other anti-VEGF agent real-world clinical practice. Okay.
Yeah.
Thank you, sir. Thank you so much, sir.
Thank you, Kaushal sir. Thank you, Deepak sir, for the wonderful presentation. So, do we have any questions to the speakers?
I think there is no question, Pratik bhai. So,
Okay, okay.
so I think we
So,
can go to
yeah, we would
close.
like to thank Dr. Deepak and Dr. Kaushal on behalf of Bayer for the wonderful scientific session. Thank you once again, sir. And thanks to all the participants, those who have joined and spared their valuable time for this scientific meeting. Thank you.
Yes. Thank you, sir. Thank you so much. Wishing you a very happy Holi and
Happy Holi, sir.
the festive fest. Yes. Thank you, Deepak sir. Wishing you a very happy Holi, sir. Yes.
Sir, can we close this session?
Yeah,
Pratik sir?
we can close.
Okay, sir. Thank you.
Thank you.